Good afternoon, everyone, and welcome to session 46 of the medical debate. And today we're going to be talking a little bit about sleep and some of the ethical issues that come into play with sleep, especially within a medical setting.
Yeah, so first of all, we're going to answer why do we sleep? It's not just to recharge yourself. There are actually many essential biological functions, as the slide says. From an evolutionary perspective, the fact that sleep exists is almost, in almost all species, despite the fact that it creates vulnerability and takes time away from feeding or procreating, is a strong indication that it is fundamental to well-being. Now, just to explain that bit a little bit, obviously one of the main things about, predation awareness is the fact that, especially in the wild for all animals, in the night, nocturnal animals can kill these animals. The fact that they need to sleep and take that risk means it's very important, so much so that actually, it might be so important to actually keep life going for these animals. In humans, sleep appears to be both critical to physical and mental development in babies, children, and young adults. In adults, a lack of sleep has been associated with a wide range of negative health consequences, including cardiovascular problems, a weakened immune system, high risk of obesity and type 2 diabetes, impaired thinking and memory, and mental health problems like depression and anxiety. Not only this, but a lack of sleep can actually result in lower productivity because you need a certain amount of REM, which we'll talk about in this PowerPoint, and without it, you can't actually focus on your goals or objectives as clearly.
Yeah, so we're going to talk a little bit now about the kind of science behind sleep and how it's classified into 4 different stages. And so that's already mentioned REM or rapid eye movement, which we're going to talk a bit about now. So the first stage of sleep is called N1, and it's usually 1 to 5 minutes long. This stage is sometimes not even classified as sleep because you're not really sleeping, it's just kind of dozing off, and your brain slowly starts to become less active, which eventually causes you to fall asleep and go into the deeper stages afterwards. So during this stage, the N1 stage, the body hasn't fully relaxed, but the body and brain activities will start to slow with periods of brief movements or twitches. And at this stage also, you might just fall in and out of consciousness. There are light changes in brain activity associated with falling asleep at this stage. During the next stage, this is a slightly deeper state of sleep. Body will enter a more subdued state, including a drop in temperature, relaxed muscles, and slowed breathing and heart rate. And at the same time, brain waves will show a new pattern and eye movement stops. Overall, brain activity will slow, but there are short bursts of activity that actually help resist being woken by external stimuli. And this stage is one of the longer stages, so it will last 10 to 60 minutes in a single cycle. Following this will be the N3 stage, which is a bit shorter, 20 to 40 minutes. And this is where the body becomes even more relaxed and your muscle tone, pulse, breathing rate will decrease even further. And the brain activity at this point will show what's called delta waves. And so this stage is also called the delta stage as well, or the delta wave stage of the cycle. And yes, as it says here, delta sleep, short wave sleep, and it has a very characteristic graph, and we'll show you that on the next slide. Experts believe this stage is critical to restorative sleep, allowing for bodily recovery and growth. So this is what most people think sleep is really about. It's about recharging, re-energizing, and this stage is where most of that will occur. And the most interesting stage of sleep is the 4th stage, REM, or rapid eye movement. This is when brain activity will pick up again, nearing levels seen when you are awake. And the eyes will appear to be moving rapidly, and you're still not awake, you're asleep, but the eyes will be moving very quickly. And they believe that REM sleep is essential to cognitive functions like memory, learning, creativity. And this is also where the most vivid dreams will occur. Dreaming can actually occur at any stage of the cycle, but the most vivid dreams that you're most likely to remember will occur during this 4th stage. And people will go through several cycles of these 4 stages in a single night. So yeah, and we've got now a few different graphs. Yeah, so Siddhant, don't know if you want to.
Yeah, so you can see in this, this is an EEG, as you can see on the left, and So as we talked about, there's N1, N2, N3, and REM. And you can see in a wave, there are a huge amount of brain waves. There's increased brain activity and awareness. As you can see in REM, and staying with stage 1, there's a lot less. Stage 2 and stage 3 and 4, if you can remember what we said in the previous slides, there tends to be some, because, I believe that's associated with a lot of dreaming and falling into the REM cycle. But as you can see, REM has virtually no brain waves. Or very, very little brain activity. But that doesn't mean your brain is not working. It's just sort of a relaxation period.
Mm-hmm. Yeah, so we're going to talk next about some sleep disorders. But before I move on the PowerPoint, can anyone think of any and put them in the chat? Any disorders associated with sleeping or that might occur while you're asleep? Just put any ideas you have in the chat.
There's one really, really common one.
Someone's put sleep paralysis. Yes, that's true. And that's one that we did come across while researching for this, but it's not one that's in the PowerPoint, I think. But yeah, it's very, very interesting one. If you have any more information about sleep paralysis that you'd like to add, please do put it in the chat. Or can anyone else think of any other disorders? Insomnia, someone's put, yes.
What can happen during sleeping? It's fine if you don't get it. Lucid dreaming. I don't think that's a disorder.
Yeah, it's not a disorder as such, but it's, the sort of experience that some people might have while sleeping. Yeah, no, I think we'll move on and show you a few of the examples that we've got. So the first we've got is insomnia, which someone did mention. So insomnia is characterized by the recurring difficulty to fall or remain asleep despite motivation and means to do so. And so, this does happen to everyone, but not, it wouldn't be classified as insomnia. So, occasionally people do struggle to fall asleep, but if this happens over a prolonged period of time, i.e. for, several years, then it would be classified as a disorder called insomnia. And people with insomnia might experience excessive daytime sleepiness as well, and other cognitive impairments while they're awake. And that's due to, the lack of REM and other sleep stages. Your body doesn't really get a chance to relax and recharge, and your memory might also be a bit, because sleeping is involved with the storing of certain memories, that might not occur as well, which might affect memory and other cognitive abilities. It's considered a chronic condition when patients exhibit symptoms for at least 3 times per week for at least 3 months. And approximately a third of adults will live with some form of insomnia, of course, of varying degrees of extremeness. But yeah, insomnia is a fairly common condition. And also there's studies to show that increased use of technology and work as well, stress can lead to insomnia, which is why, it's so important to try and avoid these things and lead a healthy lifestyle that way. Yeah, so I think we'll move on.
So another one is sleep apnea. Sleep apnea is a common sleep-related breathing disorder that occurs due to blockage of the upper airway. So as you can see in the right picture, some people might have to wear this kind of apparatus to go to sleep, so they don't have this sleep-related breathing disorder. In this condition, people often wake up choking or gasping for air, and if someone heavily snores, that could also be considered a symptom of sleep apnea. Like other sleep disorders, sleep apnea can cause excessive daytime sleepiness and fatigue, as well as various cognitive impairments. So as we said, not having enough sleep is in itself a version of cognitive impairment. However, having sleep apnea can further this. And there are 2 types. So there's obstructive sleep apnea, where the flow of air stops because airway space is obstructed or too narrow, and central sleep apnea, where there is a problem in the connection between the brain and the muscles that control your breath. So one of them is much more serious than the other, because or the cause is more serious, because obviously indications that there might be a problem with the connection of your brain and then the muscles could indicate a further problem. And I believe sleep apnea is quite common, right?
Yeah, I think it's fairly common, but again, it happens to varying degrees. So, people who need this kind of apparatus to sleep, obviously it can be quite serious, and if it can be quite difficult for them in their day-to-day lives to have to wear this apparatus. So, yeah. But, snoring, for example, is an extremely mild form of sleep apnea. It's just your body trying to allow you to breathe. Yeah, so I think we can move on, and we're going to talk a bit about anesthesia now. So anesthesia means loss of sensation, and this is how sleep kind of links to medicine. And we're going to be talking about anesthesia and a little bit about some ethical issues surrounding it. Medicines that cause anesthesia are called anesthetics. So anesthetics are used during tests and surgical operations to numb sensation in certain areas of the body or induce sleep. And this prevents pain and discomfort and enables a wide range of medical procedures to be carried out without the patient being aware of them or being, being hurt by them. So, obviously they're extremely useful, and anesthetics of some variety have been used, for hundreds of years. So local anesthetics and general anesthetics are the two main types of anesthetics, and local anesthetics is where just a small region of the body will be numbed, but the patient will remain fully conscious. They'll be able to see what's happening, they'll be able to understand what's happening. It's just that particular area of the body will be numbed down, so they won't be able to feel any pain there. And this is used quite commonly in minor procedures. If someone's broken their leg or something like that, and it needs to be reset, then a local anesthetic would be used. And a general anesthetic will be used when this is where you become completely unconscious and unaware of the procedure. And this is used in, larger scale operations, where perhaps, it would be impractical for a patient to be wide awake. It would be very painful, and a large number of perhaps different organs, different areas of the body need to be worked on. Sidan, do you want to add something?
Yeah, sorry, I just wanted to say, you might have seen in, for example, medical TV shows or in many other areas, general anesthesia is used for big surgeries, especially when you're doing anything in the abdomen or having to actively. Sorry, did you have a question?
I think it might have just been someone's mic on.
But for example, if you have to open someone's abdomen up or open a set of organs and adjust them, then it would be general anesthesia. And this also plays an emotional benefit to the patient, because it can be quite emotionally draining and difficult to be awake and being able to see your own surgery happen or see your heart in someone's hand, etc. So sorry, I'll answer that question in 1 second. Someone's asked how, when using local anesthetics, would or could doctors deal with someone who becomes very stressed in the midst of an operation because of what they are seeing? Yeah, to 1 second. And local anesthesia, there's also sometimes where you can't use general anesthesia because they may have to stay awake for an operation. So for some open brain surgeries, to be able to see the brain waves and to be able to see if the treatment is working or a certain electrode is working in a certain area, you have to have the patient awake to see what their symptoms are and how any course of action is affecting them. It says, so to answer your question, I'm not entirely sure with local anesthetics, and that would be a very harrowing experience, but hopefully the surgery is not so traumatic that under local anesthesia they become so stressed because of it. I guess it depends on the anesthetist's individual anesthetist's course of action. But yes, and there have been, I think, very few cases where some patients' metabolism have been really high. And obviously you get this in medical TV shows all the time, where someone wakes up from anesthesia in the middle of an operation, which, I mean, Shivas, correct me if I'm wrong, is extremely rare. And yeah, even then, it's for some medical metabolic reaction reason.
Yeah, definitely. And, there have been a fair few very, horrifying stories of people, waking up from anesthesia, or even worse, being awake and alert and being able to feel the pain without being able to do anything about it, without being able to tell a doctor. But, luckily that is very rare, and anesthetics nowadays are very, effective, and they're very controlled in the dose that's given. So things like problems, complications during surgery involving anesthesia, are very rare. But in answer to your question, as Sedan explained, usually would just be very small scale operations that would use local anesthetics. But often, if a patient is a bit, concerned about someone digging inside their leg or something, then the doctor would ask them to, lie back, close their eyes, and just kind of look away. So they're physically not, involved with it. But at other times, a general anesthetic will be used if a patient requests it, because obviously they might just not want to be awake at all. They might not want to be alert and seeing this operation happening. But yeah, no, it depends on the situation. It depends on the anaesthetist and the situation that the patient's in. Yeah, so I think we'll move on. Sinan?
Yep, so this is one of the ethical questions we wanted to ask. So studies show that healthcare workers in the NHS, especially those who frequently undertake night shifts, are more at risk from disorders such as sleep apnea and insomnia than other groups. This can affect productivity, mental health, and the quality of patient care. Is it ethical for NHS staff to be given extra time off work in order to sleep? What do you think? Just put answers in the chat or feel free to unmute your mic and tell us. But what do you think it is ethical for NHS staff to be given extra time off work in order to sleep? There have been cases previously where certain governments in certain countries have increased the amount of, decreased the amount of work hours that people, or especially doctors, can do to, to stop them from overworking or experiencing tiredness when dealing with patients. And, especially when there's surgery happening, you don't want doctors to be tired or not able to do something properly. So you could think about this. Or maybe on the flip side, is it okay to give doctors off time when they should be in the hospital, because a hospital is a very busy place, and if someone comes into the hospital with a difficult injury, they may need to be treated, and obviously they'd rather have their doctor in rather than at home.
I think another important thing to consider, building on from what you've just said, is that about the role of the doctor, whether it's a doctor's role to always help a patient regardless of the situation, regardless of their physical condition, or is it ethical for them to kind of give up that duty, give up that responsibility in order to care for their own well-being? Is it a doctor's role to care for themselves or just for others over themselves? It's an interesting question, but at the same time, as it says in the question here, a lack of sleep can lead to lack of productivity, mental health, and quality of patient care. If a doctor makes a mistake because of a lack of sleep, because they're not aware, because they're not concentrating, that could lead to potentially devastating impacts. And then, that shows that kind of sleep is very important for a doctor's well-being as well. So I'd say there's correlation between a doctor's well-being and the quality of care they're able to provide. But yeah, there is also a trade-off in the sense that doctors sleeping more means that they can't be giving that care. So yeah, what do you think? Please do put your answers in the chat. Any comments you have regarding this? You can talk about the 4 pillars of medical ethics as well. Yeah.
Anyone have any ideas? Just whatever you think. Or you could just put yes, I agree, or no, I disagree, if you believe that doctors should be given extra time off work, or if they shouldn't. Any opinions? Someone said, as long as it's not interfering with patient care, I think it should be allowed. I think that's a really coherent argument. And I think that covers both sides of it, that, if obviously if they're tired, then they're not going to be able to provide adequate patient care. But then on the other side, if there's not there, then that is interfering with patient care. So I think that's a really good answer. I remember Adam Kay saying in his book that his lack of sleep meant he almost injured the baby in delivery. So patient beneficence is an important factor here. Yes, it's true. It's not just about the doctor's health here. It is about also the patient's health. And as you said, beneficence, non-maleficence, both of them are really big factors here at play. And yeah, it's a really interesting point you raised. Yeah, sorry, you raised your hand. Feel free to unmute yourself.
Yeah, I just have a question. So in my previous experience as a medical assistant, I was working with a doctor who seemed to overwork himself and worked as a doctor in that private practice and then headed to the hospital where he was a hospitalist on weekends. Is there any way that the hospitals are tracking the hours that doctors are working so that they kind of like put a break on them a little bit?
I mean, I think it depends really it depends on the hospital, it depends on the country you're in. But generally, you know, a widespread concern in the NHS is that doctors are overworked. Many doctors have gone on strike because they feel like they're not, they're working too many hours, they don't have enough breaks, and they're not being paid enough for the work they do. But yeah, no, a lack of sleep is a problem, you know, commonly associated with medicine. And many people will say, if you are going into medicine, if you want to become a doctor or any sort of medical professional, then you need to be prepared for that. But in response to your question, you know, it depends. But I think most people would agree it should be a good idea to track people's hours to ensure they're not working too much overtime and that they are still getting a good quality of sleep. Because as you said, if someone is coming in repeatedly very tired, then that could affect the quality of care that they're providing. But yeah, that's a, you know, a valid concern, and I think it's a very important one to discuss. Yeah, does anyone else
Thank
have
you.
any? You're welcome. I think there's a few comments
Yeah,
in there.
someone said, however, in terms of this policy, healthcare professionals usually have to work overtime for free. So giving time off would perhaps have no effect as they would still have to work long hours. That's a good observation. Lots of doctors stay behind to check on patients. That's the same with nurses. Quite frequently, nurses have had to stay behind to keep sure that their patients' meds are stocked or to make sure that the patients are feeling okay or just check up after a surgery. And I believe that especially with healthcare, it's quite an important part of hospitality to check on everyone after they've undergone any sort of procedure. So I guess it is a specific career where that's sort of required. And yeah, that can sometimes lead to doctors staying behind when they're meant to be at home, which is an interesting idea. But I feel if you give them enough extra hours, maybe that could possibly increase their likelihood of sleeping better or just more. But yeah, no, that was interesting. Sorry, do you still have your hand raised from the previous question, or do you want to add something?
Sorry, I'll take it off.
No, it's fine. Yeah, so Shivas, if you want to move on to the next one.
Sure. So now we've got another question about anesthesia, which we discussed just a bit before. Let's say a patient comes in for an operation, and usually you'd provide local anesthetic to numb the pain, which, you know, if you didn't provide would be quite considerable. Yet the patient insists that the procedure won't be carried out with an anesthetic due to religious reasons. They say that their religion prevents them from being given anesthesia, and they will just go ahead with the operation without. Now, in this situation, would you say, okay, would you respect a patient's autonomy, their ability to decide what treatment they want, and say, we won't give you anesthesia, you can have the operation anesthesia free? Or would you, you know, kind of force them to have it? Would you say, no, you have to have anesthesia?
Watch you do the magic.
Sorry, did someone have a comment they wanted to add? If not, please just, you know, keep your microphone muted. But yeah, no, anyway, would you defy the patient's wishes? Would you force them to have anesthesia instead because of the pain that they could have? So yeah, what are your thoughts on this? Please put any ideas you have in the comments, or feel free to put your hand up if you want to speak out loud. I think, again, this is a really good case study to look at with regard to the 4 pillars of medical ethics. And I think the main ones that are at play here are autonomy and non-maleficence. Yeah, so someone has put in the chat, you would have to look at any alternatives. Sometimes not having an operation means they would refer patients to tablets, etc., even if it's not the best case scenario for them. Patient autonomy is important here. Yes, I think that's an excellent answer, because the case study we've been given is very restrictive, and it kind of just implies there are only 2 options. But you're absolutely right. If a patient doesn't want anesthesia, or they can't because of their religion, there are possibly a variety of different options that could be carried out. And like you said, you could give them tablets, or you could, think of another method by which you could treat them. And so, that's a very good answer. But as you said, patient autonomy is very important here. Does anyone else have any other comments? Or in fact, what would you do if you were a doctor in this situation? Would you follow either, A or B, or would there be something else you do? Someone's put non-maleficence is also here, yes. Someone said, depending on the type of operation, I'd suggest that they don't go through without anesthesia. I think the doctor should present to them all the consequences of the operation without taking anesthesia, and also the alternatives, as the other person said. Yes, absolutely. And this is what I was thinking as well. So I think if anesthesia would really be beneficial in this operation, if you kind of can't do the operation without it because of the huge amount of pain that would be caused, I think what's really important is to just inform the patient of the operation and the risks of the operation and the pain that would be present if they didn't have any anesthesia. Yeah, exactly as someone's just said, informed consent. Try to explain the benefits of having anesthesia so they can make the decision. Autonomy isn't just allowing a patient to just pick a decision out of thin air. It's about making an informed decision, about presenting them with all the possibilities, all the facts, and all the evidence, and allowing them from that to pick out a solution which they think would be best for them. And I think that's especially important in this case. If you spoke to them and outlined the different possibilities, you said, look, the anesthesia will be really helpful. It would be, it would completely numb the pain. And if you didn't have it, then you would be in a lot of pain. It would be quite traumatic for you. Then they might think about it and think, okay, maybe it might be best for me to go ahead with the operation, even though it might not follow my religion. I think in this case, it would be beneficial for me to do that. So yeah, like someone said, inform the patient, allow them to come to that decision themselves. If given all the evidence, they still don't want to, then you would look for another option, for example, any drugs that could be taken instead. So yeah, thank you everyone for that. Sidan, do you have any other comments?
No.
No? Okay, well, yeah, thank you everyone for that. I think we've got one final ethical question before the end. Yeah.
Cool. So someone said an elderly patient has come into A&E after collapsing. You need to perform surgery on her heart rapidly, yet this surgery does have certain risks, including death. Since the patient is unconscious, you are unable to obtain her consent. The longer you wait, the more likely the chance of the patient suffering severe complications. Is it ethical to carry out the procedure anyway without obtaining consent, or should you wait for the patient to wake up? Or would you choose another option, example, asking the patient's family? Are we assuming that the patient is above 18 here?
Sorry, what did you say?
Are we assuming that the patient is above 18?
Yes, well, it says an elderly patient.
All right,
Yeah.
Yeah, so exactly, that's, yeah, so this is more about questions about consent and, who has legal power of attorney at this point. If she's not waking up, what does everyone think? And you do have to assume that without the surgery, the surgery is the only way for her to survive, but it could also cause death. Yep, go ahead.
Yeah, so I think that as long as if the family is there, then you would ask the family for consent. If the family is not present, I would say most emergency rooms tend to do the surgery right away without asking for consent, even if the patient is unconscious. That is if there's like a form that they've checked that there's a form that hasn't been signed that says like do not resuscitate without any surgery or like that.
Yep.
But I would say overall, if the patient needs the surgery, they should just go ahead and do it.
Yeah. I agree with the family part. If the family is present, then you should definitely ask them. But obviously, if this is an elderly patient and if they've come alone and there's no one there, you have to assume that when they came in, they gave their consent to any life-saving medical treatments or procedures when they came in, because they were able to give consent. If no one is reachable for consent, then I guess you're right. They would just go ahead with the treatments. What if the elderly patient woke up after the surgery and is in extreme pain and is angry because they didn't want this surgery? What then? And they didn't consent to it, but there was no one else to stop that. Any ideas, anyone? It's fine if you don't get it. There's no really here, there's no right or wrong answer. Someone say, calmly explain to them that they could have lost their life without the surgery. That would probably be the best idea at the, from the get-go, to explain why you did the surgery and why it was necessary, and that because they had no other indication as to the fact that they didn't want the surgery, they had to go ahead because, they also took an oath to do whatever and to save that person's life. Yeah, so that would probably be the best course of action. Cool, so Shivas, if we move on to the next one, unless anyone has anything to add to this one.
In fact, I think this is the final one. So yeah, if anyone has any comments they'd like to add just onto this one. But yeah, no, I agree. Based on what everyone said, I think the family would probably be the best option in this situation, keeping in mind that this is quite an urgent matter, i.e. the patient is needs surgery immediately. Asking the family, trying to find their numbers, trying to call them, seeing if they're available or not. That will take time, and that can lose valuable seconds, which I needed to perform the surgery. So, again, in a real life situation, the most probable course of action would just be to perform the surgery if it's deemed in the best interest of the patient, if there's no indication of a do not attempt resuscitation sign or anything like that. Then that's what would happen. And like Siddharth said, after the operation, you would explain to the patient what had happened, and tell them why you did it and that it was in their best interest. And yeah, I think that's what would happen in that situation. Someone said, what if a family member says a decision for this elderly patient and the doctors don't agree with it? Right, well, it depends on, and it varies from person to person, but if a family member has, if several family members perhaps say, no, this patient, she has indicated throughout her life, she doesn't want to have heart surgery. If she is ill, if she is in pain, she just wants to die, then that would have to be respected, because that would be taken as the patient's autonomy. Their decision would need to be respected. And even if the doctors don't think it's in the best interest of the patient, it's what the patient wants. And ultimately, autonomy, supersedes the other pillars of medical ethics in that sense. So yes, that's what would happen. The elderly patient wouldn't be given an operation in that case if doctors had ascertained that it really wasn't what the patient wanted, and there are multiple sources that can confirm that. Does anyone else have any comments or questions or anything? Siddharth, is there anything you'd like to add?
So just about sleep generally, so obviously lots of people think about different things in their sleep when they're dreaming, and then also the fact that when you dream, it said that the REM cycle is working at its best, and that's when you wake up. But what about comas, for example? So people say that in comas, people are completely, there have been cases where some people were completely aware during their entire coma. So this could be medically induced, or this could just be because of natural causes they've gone into a coma. Would you say that in coma, for example, would a surgery require anesthesia during coma, or would it not, because they're already in sleep? And then my other question is, if someone is in a coma, same thing. If they have no family, do you just pretend that they have given consent for procedures if their family's not there, or do you not? Does anyone have any answers to any of those types of questions? So first of all, should we give anesthesia to coma patients if they can't feel pain, or if they supposedly can't feel pain? And secondly, should we just assume they've given consent to give them medical treatment if their family isn't there?
And I think also another common kind of ethical dilemma with coma patients is death, really, and taking people off life support, which we have covered in previous sessions. But there's always a question of, if a coma patient isn't responding, if we don't know if they're going to wake up or not, they're still using resources And, you know, should we give them anesthetic? Should we give them medication? Should we try and keep them alive, even if there's no indication that they will ever wake up? And that's a really, you know, big question. And if there are no, you know, should that change if there's no family present? So if anyone has, yeah, any comments or any thoughts on this topic, then please do, you know, put your answers in the chat. But as I said, we have discussed this in some previous sessions as well. So I think someone's put a comment. There may not be any evidence of coma patient not feeling anything, so giving them medication to be safe won't do any harm. That's correct, but you've also got to think about kind of resources in general and kind of managing resources within the NHS. The NHS has kind of a limited stock of resources of medication. So should we give that medication to coma patients, even though it won't do any harm, or should we keep it for patients who are, you know, awake and alert and some might argue, need it more? So that's the kind of trade-off, the balance that needs to be struck here.
Someone said, is there a policy that after a long period of time, stop giving medication or life support to a patient? And they've said, oh, someone's also said if they're not showing signs of improvement. Oh, right, for the same question. Okay. Interesting. I think obviously with the life support machines, a lot of the time is also the consent of the family. So if the family says, you know, you can take them off of life support after ascertaining that someone cannot live without a ventilator or live without a, they won't be able to breathe on their own. Quite a few people ethically just believe that because it's not the same person staying alive anymore, or technically they're not even alive if they can't breathe on their own or if they can't live on their own, then they choose to just stop the life support. I'm not sure about policies, if I'm honest, but I know that quite a few times consent is taken from the families for that. Shivas, do you know anything?
Yeah, I mean, I don't know, you know, in regards to your question, I don't know if there is a policy after, you know, 2 years or whatever, 3 months, that people will be taken off life support. I guess that would vary from country to country and maybe even from different hospitals. But like Sedan said, the most important thing would be obtaining the family's consent. Generally, patients are only taken off life support when A, the doctor believes it would be a wise medical decision, and B, the family have consented for that to happen. And in that case, a patient would be removed from life support. But there have been cases where the family don't want to remove a patient from life support, even if the doctor thinks it will be in their best interest. And in that case, it would usually be the case that the patient would remain on life support. So yes, I don't know exactly, but you know, we can find that out. And if you'd like to know more, please do email us or DM us and we can discuss that further. But I think generally we've, you know, discussed everything with regards to this topic. Siddhant, do you have any other things you'd like to add here?
No, that's it.
Yeah, so yeah, thank you everyone. I think we've come to the end of the session today. So if you do have any questions, like I said, please do email us on themedicaldebate@gmail.com or DM us on Instagram at themedicaldebate. This video will be uploaded to YouTube on our YouTube channel, The Medical Debate. And there you can also find all our previous sessions on a, you know, wide variety of topics. So please do check those out as well. And yeah, please do follow us, keep up to date with our upcoming videos, which we'll be releasing to YouTube as well. So yeah, thank you very much, everyone, and see you next week.
Thank you.
You're welcome.
Thank you very much for coming.